Hello, everybody. I'm super glad to see so many participants today. We started with 16 participants in December. Now in March, we already have over 100. It was one of our biggest goals to grow in number, so super happy about that. And then I want to welcome Professor Adins Bloch. He's the head of the Radiology department of Riga Stadins University. We're happy to have you join us today. Maybe most of us had a look at the screen already. It's just information where you can contact us. What I want to point out before, because at the end, usually some people have to leave early, we have still 2 open topics. So you can become an active member by presenting it. And 2 topics are still open, one for May, the scintigraphy and PET-CT, which are 2 interesting methods in radiology as well, but they're not well known, at least not for students usually. And then in September, the topic fluoroscopy and risks in cases of different radiological methods is also still open. So if you're interested, contact us. If you want to have the newsletter, there's an application form on our Facebook page. Same for the feedback sheet. And regarding the feedback sheet, I'm going to post the link in the chat right now, because most people forget, and we would really appreciate it if you take 2 minutes to let us know how you like the event. And then, sorry for the noise the whole time, it's people entering. If you are interested in general about events, but you missed them, we also have all the presentations recorded, and the sheets, the files will be in our Dropbox. Also linked to our Facebook page. And then I'm very happy to give the floor to Francie if she's ready.
Yes. Ready? Hi, good evening, everybody.
Thank you for being here with us. I will stop sharing my screen.
Yes, and is it perhaps possible to, well, I always get noise when someone is in the waiting room. So do I have to be the co-author?
I will check if you can share the screen if you're not. Let's see, wait a minute.
That would be nice. I randomly did an internship in radiology, and I was really surprised how little time we actually had in our studies when we started to study, and I think we only had a week of radiology. So I'm really glad to be able to talk a little about MRI and yeah, to learn about MRI myself. So I will start with the presentation now. Yeah, it's about magnetic resonance imaging, as you probably already know. And I have, as I started learning about the topic myself, I realized how useful it is to understand the whole functionality, to understand how an MRI actually works, and yeah, being able to differentiate between the different sequences you can choose, and thus being able to more easily find a diagnosis and to better use the tool of MRI. So I hope you're not afraid, because honestly I had no idea physics myself. So I hope you're not afraid that I will use some physical terms, and I decided to, in the beginning, explain everything from the physical aspect, and then I will explain it a little more and elaborate it with pictures and images. So please give me a little time to explain everything and don't be afraid when I start. But first of all, let me tell you a little about the terminology and the history. I think it's quite interesting. You probably all know Nikola Tesla, and he was the first in the 19th century who was describing the rotating magnetic field, which was the basic technology which was needed later on to develop this magnetic resonance imaging. And there were so many people inflicted afterwards that I have decided to only tell you about a few. 2 of them are Felix Bloch and Edward Snell's Purcell. I think you should have hurt them, because it was actually quite cool. A little fun fact: in the Second World War, they helped with the radio frequency waves to catch them and to emit them. And after the war, they decided that they want to put a little more effort into this technology, that it might be, well, handy for other things. And they were right, and received the Nobel Prize for it as well. And they realized that if you put a radio frequency wave through a substance, for example, a chemical substance, that that substance itself will emit another wave, and thus they were able to catalog different chemical substances and being able to identify substances. And that was what the MRI was mainly used for, and it was also called nuclear magnetic resonance, and it's still called that way in science. It's only today that we call it magnetic resonance imaging, because so many patients were afraid that it had something to do with nuclear power or something, and that it could be dangerous. That's the reason why in medicine we call it MRI, and in science nuclear magnetic resonance. And only in 1971, Mr. Damadian demonstrated that it's not only possible for chemical substances to identify them, but also he showed in experiments with animals that different tissues have different relaxation times. Later on, I will explain what relaxation times are. However, that gave the possibility to study different tissues, and also what he has done is to catalogize them. So to write down what waves they will emit after being hit by a radio frequency wave.
Sorry, Francie, one second.
Yeah.
So I keep getting the request that I should turn off the microphones. So I don't really know, except yours, I don't see anyone having the microphone on. But I'll try to maybe silence everyone. Give me 1 sec. Because this is for me also the first time being the host. Maybe, Jenna, do you know how that works? Is here with me?
Oh, sorry.
Okay.
But can you hear me? Can you still hear me?
We can hear you. I don't know where the sounds come from. I'm sorry. Continue.
Yeah. So yeah, that's a picture of the very first magnetic resonance imaging. I took it from Wikipedia, that's why I put the picture there, but all the other information I gave you are empirical, of course. So yeah, this is the very first machine, and it was in, I have to check, it's called Mark I, and was in the Aberdeen Royal Infirmary in Scotland. So enough about, enough about the history and terminology. Let's get to the functionality. So how does an MRI actually work? So as I mentioned before, I don't know why there is a yellow circle. Have you done it? It's not in my presentation.
Conference.
I just try to do it again. Okay, now it's gone. Okay, I will go on. The MRI basically just uses the natural magnetic properties to produce detailed images. And therefore, it uses the hydrogen ions. it uses hydrogen ions because they are most abundant in our body. As you know, soft tissue, which is a huge advantage for imaging those soft tissues. So under normal circumstances, in the normal environment, those ions are spinning around their axis with a north-south pole, and they act as little bar magnets. So they just spin freely in the body and have their axis randomly aligned.
I think I found the button. Give me 1 sec. This is really annoying for everyone.
Yeah, it is. But can you still hear me? Yeah. Ah, this is so much better. I hope you can all hear me. So I will go on. Yeah, the last point I mentioned is that we have all those hydrogen ions in our soft tissue, and they are very abundant in water and fat, but also other soft tissues. And as I mentioned before, the Median, he categorized how all these tissues will react to radio frequency waves. That's very useful because, well, step by step, I will explain now how this MRI will make an image and get to an image. And the first step is that there's a really strong magnetic field, and that will line up all the hydrogen nuclei. So the magnetic vector is oriented along the axis of the MRI. And now I will show you a little picture that makes it perhaps a little more easy to understand that. So for the nerds among you, there are around 0.5 to 1.5 Tesla by the magnetic field. And here you can see a very simplified image. So in the middle, there is this magnetic field. And the green coils are the magnetic field coils, and those are supposed to demonstrate the hydrogen ions. And when the magnetic field starts, the hydrogen ions, some of them will, well, it's called spin into the direction of the magnetic field, and they are called low energy hydrogen ions. And some of them will spin into the direction of the magnetic field. And what's really important to mention here is that the number of low energy hydrogen ions slightly exceeds the number of high energy ions. That becomes more important later. I will explain it further. I hope so far everything is clear. So we have the magnetic field and the hydrogen ions, which are aligned. So now the next step is that we will additionally put energy to those hydrogen ions, and they are able to absorb that energy and change their spinning direction to the opposite direction of the magnetic field. So from the low hydrogen ions will become high energy hydrogen ions. And thus, when the radio wave is switched off, they will spin back to their previous state. And this spinning back of the hydrogen ions will release a radio frequency wave itself, which is then received by a so-called receiver coil. I hope this is not too complicated. I promise I will show you a picture which makes it much more easy to understand. And yeah, that's basically what I've just said. And here you see the picture. So again, we have our first step, that was the magnetic field coil and the magnetic field. We have the hydrogen ions. And now this, well, pink coil is supposed to be the radio frequency coil. It emits radio frequency waves to the hydrogen ions. And as you see with those two, they will switch and become high energy hydrogen ions. Now, this was the radio frequency wave, radio frequency coil. Oh my gosh, those words. Yeah, it's switched off now, so it's black. And no more radio frequency waves are going through the hydrogen ions or through the body which lays in this field. So the high energy hydrogen ions will spin back, and this spinning back will then give or emit another radio frequency wave, here those red rays, and they can be received by the receiver coil. It's blue in this picture. So the first step, we have a magnetic field. The second step is we put power and we receive information by those spinning hydrogen ions. I hope so far everything is clear. If you have a question, you can't say anything, but perhaps you can put it in the chat and Leonie can moderate it a little.
Yes, or raise the hand.
Yeah, that would be great. Otherwise, I would go on. So we've gone through the first steps now, and now you probably ask yourself, how can I receive a specific image now? Because if the radio frequency waves goes through the bodies and all the low energy hydrogen ions will emit a signal, the picture is probably going to be very messy. And therefore, the solution to it is that it was detected that ions will only absorb energy if it's in their resonant frequency, which means if the frequency is above or below their resonant frequency, they won't absorb that energy, and then they won't spin and won't emit radio frequency waves. But before, if you just put the radio frequency wave through the body, all the hydrogen ions will spin and emit a wave. So I thought about a little comparison and image, which might make it a little easier to understand. So imagine the magnetic field is the start line, and all the hydrogen ions are lined up on that start line. And then you give all of those hydrogen ions energy, so they will all go to the finish line and emit a signal, which then leads to a messy picture. So the question is now, how can I give like one specific part of the body the right amount of energy, so only those hydrogen ions will spin? I can't change anything about my radio frequency wave and also my magnetic field. But then the idea was to put another coil, yet another coil into the MRI machine, which is called a gradient coil, along the magnetic field, which changes the intensity of the field. I will also show you a picture by that, so hopefully that becomes more clear as well. So the solution are gradient coils, and those will change the magnetic field from head to toe. So at the head, the magnetic field is much stronger as in regard to the toes. And this means that a specific emitted radio frequency wave will only give energy to a specific slide of the body. So here is a picture of what I just said. Again, you see the radio frequency coil, the receiver coil, and the magnetic field. But now you see the magnetic field is changed. It's more intense in the head area and less intense in the foot area. And now, for example, you only want to have this slice of the body, a picture of it. So an example would be, those are made up numbers, by the way, to emit a radio frequency wave, which has 70 megahertz, for example. And this leads to only those hydrogen ions in this level absorbing the energy and changing, and then emitting signal to the receiver coil. Again, here you see the magnetic field coil and the implemented gradient coil. So the magnetic field will decrease down to the toes. Okay, yeah, it's really weird just hearing me speaking and not getting any resonance. I really hope it's clear for everyone. So I will just go on. So the functionality of the MRI, that was really simplified. I hope it became clear for everyone, because it's important to understand how it works for the basic sequences of the MRI. As it's a lecture about the basic sequences, I decided to tell you a little more about T1 and T2. And later also I will emphasize flare sequences and diffusion weighted images. So let's start with T1. T1 is, well, the most easy to explain sequence, I would say. It relies upon the longitudinal relaxation, and the nuclei are put in a transverse plane. So as soon as the radio frequency wave is emitted to the hydrogen ions, that simply means that when the radio frequency coil is shut down, T1 is the time until the hydrogen ions will turn back into their equilibrium. And well, here you see some terminology you need to understand that we talk about repetition time. That's the amount of time between two successive radio frequency waves. And then there is the time to echo. That's you emit a radio frequency wave and then you get a signal from the spinning of the hydrogen ions. So basically, T1 is the sequence which only gives the frequency, radio frequency waves, and then it collects the information of the hydrogen ions that spin back to their equilibrium. And this information gets to the receiver coil, which then puts a clear image of that slide. Yeah, what might be important to mention is in this technology or in this sequence, FAT quickly realigns and longitudinal magnetization. So in T1, you will see that FAT is quite bright, and water, which needs much longer to go back to their equilibrium, needs will be black, and that's one of the main factors to be able to differentiate between the sequences. I will show you a few pictures in comparison, and then hopefully it becomes a little easier. But that's so cool because it's basically what Damadian has already described in the 70s. There are different tissues and they emit different signals, and thus it's possible to differentiate between them. And that becomes so important in the modern medicine, as you know. And yeah, so that's all I wanted to say about T1. Perhaps a few fun facts. The repetition time is 500 milliseconds and the time to echo 14 milliseconds. And that's really low. So the other frequencies will have much higher time to repetition and time to echo. And oh, I'm sorry, I just see here in my notes, I forgot a very important fact. T1, since it's only the time to equilibrium, it can be used to inject contrast medium. One of the most used contrasts is probably gadolinium, and it can be injected during the scan, and it has a very, very high signal intensity. So basically, it has a very short T1, and until the end of the time to repetition, it had the possibility to emit a really long radio frequency wave to the receiver coil. And thus it's shown very bright on the T1 weighted images. And that is especially useful, as you can imagine, you inject it into the the venous system, and therefore you see vascular structures, especially light, and that might be super useful. And not only seeing the vascular structures, but also in their breakdown of the brain-blood barrier, imagining tumors and abscesses and inflammation. And specifically due to the inflammation, I would like to mention it's very good for the diagnostics of herpes simplex, encephalitis, and multiple sclerosis, so for neuroregulation. And then we get to the next sequence. It's T2. And T2 is a little more complex in regard to T1. It basically has the same mechanism, but the TR and TE is much longer. And therefore, the information it collects and thus makes a picture out of it is, oh, there's some noise. Is there a question? Sorry? Okay, I just thought there was a question. Yeah, let's get back to T2. So the time of the repetition until the next repetition is happening is very long, and the time to echo is very long. So basically what happens in that sequence is that it waits until all the hydrogen ions are spinning back into their equilibrium, and afterwards some of them are decaying again into their natural position, and that also emits the radio frequency waves. So in T2, those decaying equilibriums are measured, and as you might remember, in T1 I mentioned that the cerebrospinal fluid is very dark. In T2, the repetition time is so long that the fluid has the possibility to realign in its equilibrium, and thus appears very bright in T2. So to compare those two, T1 is the time until the hydrogen ions spin back in their equilibrium, and T2 is the decaying from their equilibrial position. And I will show you some pictures now to better demonstrate this difference. So here you see on the left side a T1 weighted image, and on the right side a T2 weighted image. And for example, in T1, this can you see my mouse?
Yes, we can.
Great, thanks. So in T1, the cerebrospinal fluid will appear very dark, as you can see here. But in T2, it's very bright. And that's one of the main indicators, I would say, to differentiate those, and you should use them. And yeah, so the next picture I prepared is one of the brain. And as you see here, the white matter in T1 is quite gray, but in T2 it's darker. Sorry, in T1 with the gadolinium it's a little darker, but the vascular structures are very nicely seen. As I mentioned with gadolinium, yeah, that's a huge advantage that you can see the vascular structures, and especially imagine if you want to find a stroke or something. And here we have T1 and T2. I thought that picture was earlier, sorry, I got a little confused. So again, please notice this dark cerebrospinal fluid, and here the very bright cerebrospinal fluid in T2 as the main indicator to see what sequence you see. And here the white matter is gray, but here it's a little darker. And here you see a third sequence, the so-called flare sequence. And I would like to explain that sequence a little more as well, as it's quite important, especially in detecting parenchymal edema and subarachnoid hemorrhages. So what happens in this sequence, and what's so cool in MRI, is that you can basically emphasize or attenuate specific tissues, because you know, as I mentioned a couple of times earlier, tissues are categorized and catalogized. So the computer can calculate specific tissues out of the image. And what happens in this flare sequence, it's also called fluid attenuated. The TE and time to echo and time of repetition times are very, very long. It's even longer than in T2. So basically, the picture you receive is quite similar to T2, but the cerebrospinal fluid becomes brighter and brighter, and thus it's possible to subtract it from the image by the computer. And this attenuation leads to the possibility of better diagnosing and seeing the parallel liquor rooms and detecting parenchymal edema, and being able to give a better diagnosis. And this is just one of the basic sequences. I was so amazed how many possibilities of suppression and enhancements there are. So perhaps in the end of the presentation, we find a little time and I can show you some additional really cool sequences to the cases. I was very impressed what's possible nowadays. I will get back to that later during the cases. So for now it's good that you see this is a flare and you know what it is, hopefully. The next comparison I would want to show you is the flare of a patient, and there is the diffusion weighted sequence. So that's also a sequence you should have heard, and it shows the movement of water protons. So it can detect movement of hydrogen ions. And it's possible because, as we know, water always goes down their gradient, so it can move quite freely in the extracellular space. But as soon as there is, for example, ischemia, the sodium-potassium pump will switch off, which leads to an accumulation of sodium within an intracellular space. And due to the osmotic gradient or diffusion of the water will go within this intracellular space and is trapped. That will lead to a much brighter emitted, or that will lead to an emitted radio frequency waves. Oh, sorry. And then ischemias or inflammations will appear much brighter on that sequence. Notice that there is a little stroke here. Yeah. So this restricted intercellular water will lead to a very bright signal on the VI. Oh, and due to the lack of water in diffusion weighted sequences, the FET will be having a very low signal and be very dark. So to sum up the theory a little, sorry, I added a picture shortly before the presentation. I forgot about it. It's a little repetition from first semester, just for you to see the planes one more time, because I have prepared a few cases, and it would be nice if you could explain what you're seeing and perhaps giving me the plane and, well, whatever you can describe and see on the pictures. So that's just a little reminder of the anatomical planes. And yeah, we have talked so much already, so I won't talk about all the advantages and disadvantages. There are so many, but I think it would be nice for you to hear in which fields this MRI is especially useful. And well, I think neuroradiology is very interesting, and since it's my presentation, it shows quite many cases because I just think it's the coolest. I hope you like it too. And for neuroradiology, it's just an amazing tool, but also to show many soft tissue structures. So MRI is very useful, for example, in breast cancer staging or pathological changes in breast tissue. It's very, very useful for pathological changes in inner organs, but also in muscles and joint tendon changes. Yeah, just a little heads up, I'm not so interested in orthopedics. I'm sorry, in case you hope for some cases in that regard, but yeah, you will see them later. They are mainly neuroradiology. I'm so sorry, I'm talking so much. Neuroradiology cases, and I have also prepared a breast cancer case for you. Yeah, but one more thing, but you probably already know, advantage of MRI is it has no ionizing and X-rays, and it's very nice to even find very small structures. But it also has some disadvantages. Usually we won't start with an MRI since it's super expensive, and it is so much, it's so loud, and it takes such a long time to take images with an MRI that it's not very useful in emergency situations. Also, it cannot be used with patients that have metal implants, like really old pacemakers. Even old tattoos might have metal inside, or if there is anything in the patient, or even if a patient might be claustrophobic, it's also contraindication, sadly. But yeah, there are many more disadvantages. I won't count them all on, but yeah. So I'm very excited. We can now start our very first case I have prepared for you. So just a few informations about the patient. She is 35 years old, and in the last couple of days, she has experienced a couple seizures. And now I have chosen a T1 weighted image. Can one of you perhaps explain what, like just what they see and perhaps changes and the plane? That would be great. So we actually
either use the raise the hand button or the chat, because somehow there's still people joining all the time.
Yeah, just so we actually use what we've just theoretically learned for our clinical cases now. Can you see some pathological changes in that tissue here?
So I guess I got
Konstantin, we can't hear you. But you're
so as you said, it's a T1 weighted image.
Yes.
And on the left side, in the left hemisphere of the brain, there is a black dense no.
Yeah. How did you realize it was a T1? Ah, sorry, I said it. Shoot. Okay. I actually wanted to say nothing, so you can find out about it. So yeah, you're right, it's T1. And can you tell us a little about the plane? Ah, shoot.
There is no hand.
Yeah, sorry, I was a little confused with the microphone. I understand that we turned it off. Yeah, thank you, Konstantin. However, I thought it would be nice to use the basics we just learned to describe the picture a little, and that's very important in the work of a radiologist later as well. So first of all, we see a T1 weighted image, and it's a coronal view. And as you rightly said, there is a mass on the inferior aspect of the superior frontal gyrus. And what's also important to mention is that the lesion is hypointense. And it's difficult to say in T1, but it's already visible that there is not really an edema, especially because the midline is not shifted, as you can see. It's straight. That's always a good indicator to say if there is edema or severe swelling. And the next picture I will show you of that patient.
And for the next question, Francie, can you see the chat? Because a lot of people participated there. Maybe that's easier. Can you open it?
Yeah, can open it. Yeah, you guys are right. It's coronal plane and it's hyposignal. That's right. And it's now, as I said, it's still difficult to make a diagnosis. So I will show you the next picture. It's a T2 picture. And as we learned before, inflammation and T2 is very bright. Just a little hint. And perhaps you can write a little what you see here. If it's perhaps easier, do you think there is edema or not visible? It's the right side. It's the right hemisphere. You basically look from down. And yeah, what you see, it's a very high signal. So yeah, it's hyper intense. That's also very nice that you mention it. It is in T2, so we can already say it's inflammation. There's also slight edema. And only by seeing the T2 and this picture, we can already conclude that there is probably a cortically based tumor. And the possible diagnosis for it is that it's a dysembrioplastic neuroepithelial tumor, that it might be an astrocytoma or oligoastrocytoma. So those three diagnoses might be possible. And what's so cool now with the MRI, I show you the next picture. This is a flare sequence. And perhaps you remember earlier, I told you that especially in the inflammations are very, very bright in the flare sequence. And now you see, can you describe what you see here?
So someone already guessed abscess, which is in the direction of an inflammation.
Yeah. Well, as I mentioned, it's already clear that it's some kind of tumor, and because of the location and the hyperintensity in T2, we have three differentials. So it might be so neuroepithelial tumor, astrocytoma, or oligoastrocytoma. And it's not an abscess, not encapsulated, but what's very confusing is that it's very, very bright in T2, but so hypointense in the flare, since the flare should actually show us very bright inflammation. And that's a really cool case, I thought, because the clue about it is that this sign is called a flare mismatch sign. So the flare sequence doesn't fit to the T2. And that's very, very highly specific, about 96% for a diffuse astrocytoma. So without even checking the patient, you are already able to give a quite certain prediction of what it's going to be just by imaging and just by changing the different sequences, which shows once more how valuable the MRI tool is. So after this imaging sequence and description of the patient actually got surgery, and the histology and immunohistochemistry confirmed it's an anaplastic astrocytoma. So yeah, I thought a very cool case just to show you. So if it's okay, I will go on to the next one. It's again a neurological case because I just love that so much. So a few information for you. We see the patient who came in is female. She's 45. And lately, she had a progradient right-sided hemiparesis. She also experienced seizures in the last few days, and there is no history of any comorbidities. So the first picture I show you and was done, it was a CT, and this was seen on the CT. Can you see anything? Could you describe if you see changes?
Hypodense area,
Yes,
the frontal part.
yes. On the left side. Yeah, right. There's severe edema. Also, again, visible with a midline shift. Lack of stretches, yeah. Yeah. Calcinosis, that's really cool that you could already guess that. But however, so this CT was fastly done due to the acute situation, and you can already evaluate there is a midline shift. But the next step, definitely, especially in those cases, is to do an MRI. And that has also been done here. So that is the MRI of the patient. Could you, yeah, there definitely is a hemorrhage. Could you perhaps tell me what, due to the theory I told you, what sequence you see here and what plane? Hemorrhage in a tumor is a good guess, but it's wrong. T2, yeah, that's right. That's right. Echinocosis is a really good guess, Maurice, but not quite.
Sagittal and transverse was guessed. Oh, and axial. Well,
Yeah.
we have the whole spectrum.
Yeah. Well, just it's not a stroke. Yeah, as most of you saw, there is a severe edema and there is a structure here in the left hemisphere. So this structure itself actually is already very highly specific again for a specific disease. And that sign is called the concentric target sign, and it's very highly specific for neurotoxoplasmosis. And that's very, very often seen in immunocompromised patients with cerebral toxoplasmosis or CNS lymphoma. However, the question is, because we learned before, there is no history of comorbidities, and that is such a severe, well, confirmed toxoplasmosis, cerebral neurotoxoplasmosis, that the patient was further checked. The blood was done and immunochemistry, and actually it was found out, and you should always check that if you have such a severely obviously immunocompromised patient, that such a neurotoxoplasmosis is possible. So check the blood, and she was actually positive for HIV, and it was unknown. And also her immunochemical findings were positive for Toxoplasma gondii. So IgG and IgA were severely increased. And one more thing I just need to tell you, because I've never seen so low T cell numbers. That lady had 7 T cells per microliter. I didn't even know it's possible to live like that. And she came into the hospital without any comorbidities, she said. So yeah, that's a diagnosis with AIDS. And afterwards, she received antiretroviral therapy and antitoxoplasmosis therapy. And yeah, that there is unfortunately no history if she survived. But yeah, another very highly specific sign to be able to give a specific diagnosis and do some diagnostic. Sorry, one thing I forgot to say, it's you're right, it's axial plane. Yeah, I think we didn't talk about that earlier. And let's go to the next case. I got convinced that we should something else than a neurology case. So I have chosen this woman. again, a woman. I'm sorry. I hope you don't think it's sexist that we only have female patients. And yeah, some information about her. She's 40 years old, and she had felt a hard, painless left breast lump on her left side. And yeah, an MRI was done, as you can see. Could you tell me what sequence you see here? It's a little mean, but try. Yeah, very good. The first answer was the gadolinium contrast was what I was looking for, because you see so nicely those vascular structures, and that's only possible with the contrast. So the investigation of choice actually in those patients who feel a lump is MRI, because it so nicely shows the size. And in her case, it was also already, well, as you see, she has this ovoid mass lesion. And in order to decide what the best further treatment is for her, it's very important to determine if the blood flow is there in case she gets neoadjuvant chemotherapy is possible and useful. So yeah, T1 with a gadolinium was chosen. And as I mentioned before, MRI is so cool and so futuristic, it's possible to depress specific tissues. And in this case, there has been a fat suppression and a gadolinium injection, and the T1 was chosen, that's right. Ah, very good. Remus just asked if there are lymph nodes. That was actually my next question. I hope you can actually already see them here. And also here, later on, I have a picture where it's even better visible. So yeah, there are lymph nodes visible. And that again emphasizes how important this MRI is in breast cancer staging, because you can see the lymph nodes, you can see the mass. And actually, it's also possible to calculate the exact volume. It's 268 centiliters, cubic centimeters. Sorry. So unfortunately, there was no further information in that case, but I wanted to show it to you because it's so nicely seen here. And I have some more pictures. So this is the T2 sequence. And here again, you see very nicely inflammation, but also some hypointense structures. So you can already diagnose there is some tissue necrosis going on. And yeah, also some edema is perhaps visible. And yeah, one more thing here. That was what Remus already saw before. Yes, that are lymph nodes here. And some facts of MRI and breast pathologies, that about 69% of breast cancers are detected in MRI. I think that's quite a high number. And what's especially important about that it can also detect lesions which are under 1 centimeter. So there's a very early detection possible. The mean size of those lesions is about 0.8 centimeters. So quite small. And this early detection can lead to a very, very early treatment phase and thus improve the survival rate dramatically. Unfortunately, as I mentioned before, oh, nice. Yeah, sorry, I'm confused a little by the chat. It's also mentioned that there's some skin thickening seen. And yeah, sorry, I get confused with the chat. So as I mentioned, MRI is very, very useful, but unfortunately super expensive. and 10 to 15% of carcinoma in situ are undetected in mammography. So they could be detected in MRI, but yeah, usually it's only in mammography chosen. And indication for an MRI instead of only mammography would be in a patient who has a BRCA mutation, who has a very high risk of developing the breast cancer, also in patients with Lymph syndrome. And in case the lump was already felt, like in this case, it's very nice to evaluate the extent of the disease, or if the neoadjuvant chemotherapy is possible, to evaluate, is there a blood flow to the lesion? Otherwise, there would be no sense to do the chemotherapy. And yeah, for staging, it's also very important. As I mentioned before, unfortunately, there are no further information because the patient didn't came back. But I wanted to show you, if it's okay, I don't know the time, if it's okay for everyone. I have one more case, but also I would love to go online. I'm not sure if it's possible. I would love to show you what's even possible with an MRI. So
it's only been an hour, so I think you're good to go.
Yeah, okay. I would like to show you my internet. Is that okay? Can I? Do you see that now? So I have some of the cases up here. Wait. Yeah. Can you see my internet?
No, we can only see this upper bar.
Ah, shit, okay. I thought perhaps it's possible to go on the Radiopedia page and do you see it now?
Yes.
Ah, great. Because I just wanted to show you what's possible. So I showed you the T1 with the fat saturation, but it's also possible to see it like this. So you actually see, well, Doppler, how the blood flows. And I thought this image was really cool. I don't know if you're so excited about it like me, but yeah, it's just insane what's possible nowadays with the MRI. And yeah, I will then go on to the next case.
There was one question. I don't know if you know the histology of the breast tumor. Was it lobular or acinar?
No, that's what I meant. Unfortunately, the lady didn't go, didn't do any further therapy, and the case ended after the MRI. So, one moment. I will share my screen again with the PowerPoint. Also, I will give you the presentation afterwards. So it'll be possible to look at the sources, and then you can again check the pictures. What I just showed you is really cool. And also I can highly recommend this page, how equipment works. There is a step-by-step explanation how an MRI works. But you should be already experts in that, of course, after my presentation. No problem for you anymore. Okay, so that's my last case, in case you're not tired yet. It's also a very special case. So the lady, oh, I just realized it's again a woman. Leonie, you should have told me something. Yeah, I love women. So she's 60 years old. She had 2 children. She was pregnant twice and gave birth to 2 children. And she came to the hospital with the right lower abdominal pain. And she has no significant medical history or family history. And well, first, when she came, CT was done, I think. Sorry. An ultrasound was done and nothing really was visible. And then in the second step, they decided to take an MRI. And A, can you tell me what sequence you see? I will open the chat for a moment. Oh, sorry, I had the chat closed, so I didn't see your questions. Yeah, it was a 3D reconstruction possible with the T1. And yeah, now about that case. Yeah, in A, right, Vince, it's a T2. And what's visible here is that there is a, beginning from here, there is swelling of the posterior uterine wall. I hope you can all see this. And in B, what sequence do you think is that? Good guess, but it's actually it's just T1. And you see very uniform uterus actually. And perhaps it's visible here, the edges, they're a little, well, not so smooth. But that's not really a huge, well, you can't really diagnose a big thing there. And yeah, C and D, I didn't emphasize too much, but in C, you actually see, sorry, I'm confused by the chat. So one thing, Remus and C, it's a diffusion weighted image, and that's nice because we actually see there is an inflammation because there's an hyperintensity. You see it here. And the differentiation of A and B and T1 and T2, it's in the inner organs, it's a little more difficult. But as I told you, fat is quite bright in T1 and a little darker in T2. And yeah, but I just really, in the picture I have in my, in the case, it's better visible. So I realize it's difficult to differentiate T1 and T2 here. But here there is the bladder. That might be a good indicator. In T2, it's very dark. And in T1, it's lighter. So yeah. Yeah, right. The bladder is a really nice indicator. Thank you for your help. Sorry, I was a little, I didn't think about that question before. Yeah, so yeah, all in all, the imaging, the MRI is not very helpful in that case yet. So furthermore, what was done, there were some cytological analyses of the endometrial tissue, and they were negative. So there are two tumor cancer markers, the serum carcinoembryonic antigen and the carbohydrate antigen 19-9, and both of them were within the normal range. And the cytological analysis was negative. And the diagnosis for the lady when she was released was adenomyosis, so endometrial tissue within the myometrium. That was also based on the findings here in B, that there were not so smooth borders. So after 4 months, the lady came back with the same problem. She had severe pain, and she wanted to be treated and checked because the pain was during the whole month, not only when she had her period. So after 4 months, after the initial MRI, another MRI was taken. On A, what can you see? Under the bladder, there is the symphysis, so it's a bone. In case you mean that, Vince. And can you tell me the sequence in A, perhaps one more time? Then I'm an expert in it as well. I just learned that thing with the bladder. It's really nice and handy. Yes, A is T2, that's right. And B is T1. And C is fat saturated T1 in this case. And what becomes visible in comparison to the first, the posterior wall is even much more thicker. And see the borders here? They are not so smooth at all anymore, and there is even edema. So the decision was that there needs to be a surgery done, and the decision was based on PET-CT, which was also done, and she had para-aortic lymphadenopathy. She also had severe thickening of the posterior wall, as you can see here in the MRI, and the markers were not within the normal range. So it was decided to do a surgery, and while or during the surgery, they detected microscopically, or they did laparotomic surgery and detected that the posterior wall, there is adenocarcinoma. And that led to the conclusion that they did a radical hysterectomy. They did lymphadenectomy of the para-aortic lymph nodes, omentectomy, a pelvic lymphadenectomy, and afterwards they decided to give her a 6th cycle of chemotherapy. And after 1 year, she came back and she was still healthy. So yeah, and after the surgery, microscopic evaluation showed that the cancer actually arose from the adenomyositis. And this is a very special case because that's extremely rare. Usually it arises from the endometrium, and now it arose from those from this changed cells. And there is no staging for that kind of cancer yet, and therefore it's a very specific and special case, which has a high significance nowadays because they try to evaluate and elaborate the staging for those patients. Yeah, that are all the cases I've chosen. I hope you like them. Perhaps in the end you can think of any questions or something that stayed unclear.
Someone already asked in the chat, could you specify, Claire, what is different from T1, T2? You talked about it a little bit already. Maybe you can repeat it.
Yeah, thanks for asking. I have decided upfront that I won't put so much information on all the slides because it's always a little difficult to read and listen. So I will mention it one more time. And one moment. I have the specific, yeah, it's, I had this picture and perhaps I go back to it, perhaps it's easier. How can I? That was in the comparison actually. So here you see a FLAIR. FLAIR stands for fluid attenuated sequencing. And what's so special about that sequence is that it's basically made like in the T2, or like in T2, it has a very long time to echo and very long time to repetition. That means the spin of the hydrogen ions will, after the radio frequency wave, they will spin back in their equilibrium. And what happens afterwards, if there's no new radio frequency wave, they will even spin further back to their natural spinning and alignment, and that will also emit some energy, which can be put in a picture, and that's basically what you see in T2. And in the flare sequence, this time frame is even longer. So what I've mentioned in T1, water needs a very, very long time to go back to its equilibrium. And in T2, you can already see it's very bright because it had much more time to emit a signal. And, oh, sorry. How can I go back? Oh, shit. Yeah, there. And what happens in this flare sequence is that the very bright, hyper-intense signals get attenuated, so subtracted from the image, and therefore those liquor rooms can be very nicely seen, and also the rooms. So if there are edema or hemorrhages next to those liquid rooms. And therefore the sequence is very useful. So for edema and subarachnoid hemorrhages, for example. I hope that answered your question.
Yeah, maybe, Professor, I saw maybe a little nod. Would you like to give a comment to that maybe? Or is everything fine, what we're saying?
And that would be actually great. You're professional.
You mean about the flare sequence?
Yeah.
Flare sequence is a special sequence. It's a fluid attenuation inversion recovery. I don't know deeply in physics, but on flare sequence, the cerebrospinal fluid will be zero. Machine is registered image or signal when fluid signal is zero. It means we are better see the pathology which is nearby of the liquor pathways, like ventricles or cerebrospinal fluid into the sulci or subarachnoidal spaces. And it's all signals are enhanced a little bit compared to the T2 because small plugs or small dots were not sometimes able to see nearby all the ventricles or subarachnoidal spaces into the cortex, but on flare sequence we see very nicely. This is a special sequence for the brain. We do not use flare sequence for other parts of the body. Nowadays, the commercials are trying to make a flare sequence for spinal cord, but still now it's very lot of noise is coming from the spine on flare sequences. But for the brain, it's a perfect. And I know that in every clinic or early hospital, which have an MR, in the brain protocol is including flare sequence. T1, T2 weighted image, flare, diffusion, and susceptibility weighted images as well.
Okay, thank you very much for the comment. We have 10 minutes left. We set 1.5 hour max for today. If you have any other comment to anything in the presentation, you're welcome to share. Otherwise...
May I say something?
Yes, of course. Please.
Okay. No, I'm working with MR more than 25 years. It's of course it's a very nice imaging tool, as you've seen as you saw on presentation. Thank you, Francisco, for such a nice presentation about MR basics, physics basics, and during these last maybe 20 years. MR increasing the quality of the images, and more new sequences are coming into the market or clinical practice for detecting pathology. You see the MR we are using for central nervous system and for the musculoskeletal system as well, and for abdominal cavity examinations, and even for the vessels, we have a special angioprolinum contrast. It's a very interesting topic, and you can speak with them about MR, I think, a lot of lectures. Yeah. My suggestion is that maybe some days you can make a topic about MR safety, which is very interesting, about these metals, because nowadays companies are producing the implants, medical implants, and cardio devices as well, which is usable for MR imaging. And it's a very interesting topic, and as for you as a new doctor, it will be very fruitful to know which patient we can examine, which are not. And the same with gadolinium. We are not administering gadolinium for all patients, because gadolinium is uptaken by some cells of the body, like brain cells and bone cells. That means that if we are using gadolinium with special indications, and that is very important to understand why. Maybe in the future you can organize such a nice meeting, but otherwise it was perfect. Thank you very much for invitation, and thank you very much for organizing such.
Yeah, thanks again for being here with us. Actually, we do have an event planned on that in the next semester about the risk of radiological methods. So thanks for mentioning that. Yeah, and then again, a big thanks to Francisca, of course. I really loved the presentation, and I also loved how I could see in your face that you were like really amazed by MRI and what it can do. Thanks for like being here with us. To all the rest of you, we're still 100 participants. I'm flashed by that. That's amazing. Yeah, find us on Facebook, find us on Instagram, follow us, and then I hope to see you again next time, and fill out the feedback sheet, please.
Thank you very much.
Thank you. Bye.
Thank you so much.
Bye.
Thank you all.
Oh, maybe I turned it on. I forgot to take it off now. Okay, I think, should I just?
Yep.
I thought maybe the professor would stay, but he doesn't. So, Vaihab, can you stop the recording? Perfekt.
Jemand rein.
Ich schreibe mal bei WhatsApp.